All right, everyone. Today we will be talking about the integumentary system, which is chapter 6. Some of this we actually covered last chapter under tissues. We talked a little bit about the skin. So we'll go a little bit more in depth into the integumentary system this chapter. Um, so again, some roots, prefixes, and suffixes that you'll need to learn for this chapter. All right, so the skin. We have the skin and its accessory structures, such as the hair, nails, some of your glands, like your sweat glands, your sebaceous glands, like your acne glands, and the glands that produce the oil for your hair, and your sensory receptors that let you know the stove is hot, or that let you feel pain when you step on a tack. They all make up the integumentary system, specifically the skin. When the skin is actually an organ, and it's the largest organ by weight of the body. We learned last chapter that it has several tissue types, and we also learned that it's called the cutaneous membrane. So remember that if you're looking for the answer for skin, it might not be called skin, it might be called the cutaneous membrane. And it's named for the type of epithelium and that underlying connective tissue that we talked about last chapter. And that's just kind of like the definition of a cutaneous membrane. What type of epithelium and that underlying connective tissue. We know that it acts as a barrier against the external environment, and that it provides protection, thermoregulation, sensation, some metabolic functions. We did see last chapter that there is an epidermis, which is the outer layer, and the dermis, which is the inner layer. The epidermis, that outer layer, remembers that stratified squamous epithelium, stratified multiple layers, squamous, thin and flat cells. Remember, we name it for that top layer of cells, not the bottom layer of cells. And that epidermis has that basement membrane, or that stratum basal layer, which connects or separates that epidermis to the dermis. The dermis, so the stratified squamous epithelium, or that epidermis layer, would kind of run from here to here. And then so it's like that darker, actually would run actually all the way from the top to the bottom. My bad. All right, so then underneath the epidermis, so this would be the epidermis, and then the dermis is the inner layer. It's much thicker than the epidermis. It's made up of a lot of connective tissue. You can see the dense, irregular connective tissue down here. It doesn't have that wave-like pattern that we saw with the dense, regular connective tissue. We saw last chapter those collagenous fibers, those elastic fibers. We'll see here in a couple slides that there's some muscle down there, some blood vessels, some nervous tissue. And that connective tissue in that dermal layer gives its elasticity and toughness. Remember, elasticity is its stretchability due to those elastic fibers. That toughness is going to be due to those collagenous fibers, or those collagen fibers. All right, and then, like I said last chapter, we have that subcutaneous layer, or that hypodermis layer, that's really not considered part of the skin, but we still talk about it. It's basically an insulation layer, shock absorber. It's made up of both areolar and adipose connective tissue. So collagen fibers, elastic fibers. And it also has blood vessels that supply the skin. Um, if we go back up here, this epidermis, and we'll see this in a couple slides, this epidermis does not have any blood vessels, which is, like I said last chapter, why you don't bleed with the paper cut. So it's the hypodermis and the dermis that would provide the nutrient source for the epidermis. All right, so here's kind of a picture view of the skin. So you can see the epidermis is very thin. The dermis is much thicker than the epidermis. Then we have that hypodermis or that subcutaneous layer. You don't see any blood vessels in this epidermal layer, but you can see the blood vessels in that dermal layer and in that hypodermal or that subcutaneous layer. We can see in that dermal layer, the dermis, lots of blood vessels, muscles, nerves, lots of glands. We have the sweat glands. We have glands that are attached to our hair follicles. All right, so remember that we have those 5 layers of the skin, the stratum, corneum, and remember stratum just means layer. So the corneum, lucidum, granulosum, spinosum, and that basal is that basement membrane that connects the epidermis to the dermis. And we have what's called thick skin and thin skin. Thick skin is only present on the palms of our hands and the soles of our feet. And then everywhere else on the body, we have thin skin. So in thin skin, we're actually missing this stratum lucidum layer. So on thin skin, we only have kind of 4 layers of skin. And then on our palms of our feet and our palms of our hands, soles of our feet is where we see that stratum lucidum layer. In that stratum basal layer, we see a bunch of columnar cells, but we still call it simple squamous epithelium because way up here is where we see those squamous thin and flat cells. And this is in the stratum basal layer, that's where mitosis happens in this basement membrane. And then as new cells regenerate, these cells will get pushed up towards the stratum corneum layer. And then eventually, they brush off, or you wipe them off with a towel, or they just, fall off naturally. And remember, there's the 2 mnemonics, top to bottom. Come, let's get sunburned, or bottom to top. Britney Spears glows like candy. However you want to remember it, just remember it. We have different types of injections that we can do. Intradermal injections. Those are administered into this layers of the skin. So if you've ever had a TB shot before, it goes kind of right here in your forearm and it kind of makes a little bubble. Those are intradermal injections. Subcutaneous layer goes into that subcutaneous injections go into that subcutaneous layer. So think of like your insulin shots that you put in your belly. Those are going to go into kind of down here into that adipose areolar connective tissue layer. Intramuscular injections, those are going to go all the way through those 3 layers and into your muscle. So those are going to be most of your shots that you get, your vaccines. If you ever, those are your hypodermic needles. So those are going to be most of the shots that you get. are going to be usually given in your arm or in your butt muscle, your gluteus maximus muscle. We also have transdermal patches. Those are going to be placed pretty much anywhere on your body. Those are going to be pretty much medication patches that can diffuse. Where am I? There we go. Diffuse through your skin. The medication is actually in this patch and it absorbs through your skin. If you've ever seen people that have patches behind their ear, those are usually scopolamine patches. You see them if you've ever been on a cruise, people will wear them. People who wear nicotine patches, or we can give nitroglycerin patches that people can wear on their chest. Or some people, cancer patients, might wear a fentanyl patch. So there's a lot of different types of medications that can be administered through transdermal patches. One thing to note is that if you have a patient with a patch on their chest and you have to defibrillate that patient, or you have to shock that patient, make sure that you remove the patch of medication from the skin before you shock that patient. All right, so we know that epidermis is stratified squamous epithelium, multiple layers, and that top layer is squamous cells, thin and flat cells. The epidermis is avascular. It doesn't have any blood vessels. Remember, no blood vessels in this layer up here. So it's actually nourished by blood vessels in the dermis. So in the dermis, we have a bunch of blood vessels here, a bunch of blood vessels. So that's how the epidermis gets its nutrient supply from the dermis. We know that the deepest layer is called the stratum basal, also called basal cells. And in some older textbooks, you might see this layer called stratum germinativum. I haven't seen that word used in years, so just know that you might see germinativum. But anyway, like I said, this is where cells undergo, or this is where cells are being replaced. And I'll just write mitosis there. Remember that we have thick skin on the palms of our hand and soles of our feet that, in that stratum lucidum layer. And then most of our body contains that thin skin or that thin epidermis. So thin skin is missing that stratum lucidum layer. All right, so some of the functions of the epidermis, we talked about this last chapter. Protect against water loss, harmful chemicals, mechanical injury, and pathogens. Our skin is a good barrier. Unless you have some sort of open wound, our skin is a great barrier to protect against pathogens from entering our body. I used the analogy last chapter about, going in the swimming pool and not absorbing all of the chlorine. And we talked about the whole keratinization process last chapter. And as cells grow, that mitosis happens in that stratum basal layer. And as they grow, they're going to migrate from that stratum basal layer up to that stratum corneum layer, away from all of those blood vessels in that dermal layer. And as they move away from the nutrient supply, they're going to flatten out and die. They're going to kind of shrivel up and die. So they're going to actually become these things called keratinocytes. And they're going to go through this process of keratinization where they become hard. dehydrated because they're not receiving any nutrient supply. They're not receiving any water, any nutrients or water from the dermal layer. And this keratinization, hardening, they're going to become waterproof. And keratin, which keratin is basically this tough, fibrous, waterproof protein. It's going to accumulate in these cells as they migrate out towards that stratum corneum layer. And as they migrate out, they're going to develop these desmosome junctions to kind of help them. Remember, those desmosome junctions are really help them to stay tightly packed together, also for protection. And then those stratum corneum cells are eventually shed from the surface. So, and actually I should move this down. So when you vigorously rub your skin, you're actually shedding keratinocytes and stratum corneum cells. All right, so more about keratin. So if you ever heard the term corns, they're basically keratin. And they're kind of conical masses. Sometimes they appear on older people's feet. Calluses are thickened areas on your palms and feet. If you don't do manual labor and your dad makes you go outside and rake leaves, after about an hour, you might have a callus on your palm from the friction of the rake on your hands. And we talked a little bit about pressure ulcers or decubitus ulcers and the importance of turning your patients every 2 hours. So necrosis is basically the death of skin cells because of a loss of blood supply. So we talked about that when we talked about apoptosis and natural programmed cell death versus unnatural programmed cell death, which is necrotic skin. And I use the example of pressure ulcers. All right, so here is a summary slide of the different layers. Obviously, you're going to have to memorize the 5 layers of the skin. Know that stratum lucidum is only present in thick skin. So know that the stratum basale layer has that cuboidal or columnar cells, and that's where mitosis happens. All right, we'll cover this a lot more in lab. And by the time you actually listen to this lecture, we will have covered it by lab because this is usually our one of our first labs. But you should be able to identify these layers in lab. All right. All right, so we also have within the epidermis, we have special cells. 2 of these types of cells are dendritic cells. Actually, we'll talk about 3 cells, 3 types of cells: dendritic cells, tactile cells, and melanocytes. So dendritic cells, we also call them Langerhans cells. They're going to be found in that stratum spinosum layer. That's going to be that 4th layer from the top. So dendritic cells are going to be in that 4th layer. So just above that stratum basale layer, next to the bottom, they're going to be phagocytic. So they're going to gobble up stuff. And they actually help trigger an immune response when microbes invade the skin and underlying tissues. So they're going to gobble up microbes and they're going to take them to the lymphatic system for destruction. And we'll learn what happens in the lymphatic system next semester. Tactile cells. Tactile cells here, they're found in the stratum basale layer or that bottom layer. Um, and they're associated with kind of sensory neuron endings, um, or sensory nerve endings. We can also call them Merkel cells. We'll talk about Merkel cells and Meissner's corpuscles, but they act as receptors for light touch. So when we get to the nervous system, we'll learn that we have sensory neurons or sensory nerves and motor nerves. Sensory nerves pick up information and take that to the brain. The brain processes that information, and then the motor nerves will provide some sort of output. Your sensory neurons would tell your brain, hey, the stove is hot. Your motor nerves, and then your brain would say, oh, yep, the stove is hot. And then your motor nerves would actually remove your hand from the hot stove. So Merkel cells or tactile cells, remember light touch. The other cells, melanocytes, remember that we talked about blasts, sites, and clasts, as far as suffixes, and kind of remember what each of those do. So melanocytes, if you've ever heard of melanin, what provides skin color. So melanocytes down here, found in the stratum basal layer, that basement membrane layer, they're going to produce that pigment melanin. Again, part of the epidermis. It actually comes from the amino acid tyrosine. And these melanocytes, or that melanin, actually absorbs ultraviolet sunlight to produce skin color. And then that melanin is distributed to these things called keratinocytes. We talked about keratinocytes up here. And they do provide a little bit of protection from ultraviolet exposure. All right, so skin color in itself. It's mainly because of the amount of melanin that those melanocytes produce. And a general rule of thumb is that the more melanin you have, the darker skin that you will have. However, there is a genetic component to it, because you can take a person who has white skin, and they can lay out in the sun as long as they want, and they will never be as dark as a person who has naturally dark skin, or who has or who is Black or African American, and that is because of the size of these melanocytes, or these pigment granules of melanin. So if we're looking at darker skinned people, these melanocytes actually contain one large pigment molecule. And if we're looking at lighter skinned people, those melanocytes are more clustered, 2 to 4 smaller clusters of pigment granules. So they're going to be their pigment molecules, or pigment granules, are more spread out. So that's why a lighter skinned person can't ever be as dark as a naturally dark skinned person. A naturally dark skinned person has large pigment granules compared to a lighter skinned person. And these granules are actually called melanosomes. They're actually an organelle inside the cell, which we didn't talk about in chapter 3. And basically, they just serve to transfer the pigment from melanocytes to nearby keratinocytes. We also have, we can also look at what our hair color is. Um, Basically, you can look at the pigment. U melanin, EU melanin is going to be responsible for dark hair, and this compound called pheomelanin is going to be responsible for blonde or red hair. And remember that melanin is confined to the epidermis. Melanocytes are confined to the epidermis. So therefore, melanocytes produce melanin. So melanin is going to be confined to the epidermis as well, which makes sense because as you tan, your tan doesn't last for very long. Um, these cells reproduce, and if you have the melanin, you tan, and then your tan is going to fade as those cells migrate to the top of, your stratum corneum layer, and then those cells kind of brush away, and then your tan fades. All right, this picture just shows some melanocyte. That's a melanocyte nucleus. There's your melanosomes. Um, just some more melanin granules. More melanin granules. All right, some other factors that affect your skin colors. Hereditary factors. We know that um, heredity, I couldn't say that word. Heredity plays a role um, in your skin color. So we do have a varying degree of how much melanin is produced because of our genetic expression or our mom and our dad. We do have various varying distribution of the size of melanin granules. There are conditions out there called albinism. If you ever heard albino, it's actually an inherited mutation where the person really doesn't have any melanin. So they're going to appear very, very, very white. We also have this genetic condition called ichthyosis. Um, and I actually put, if you download the slides, there's a web address link that you can click on in the speaker notes that shows you a picture of ichthyosis, or you can just Google ichthyosis. But the skin is actually kind of rough and scaly, kind of brown, and that's the stratum corneum layer really can't. That stratum corneum layer can't peel off, and so it's going to affect the epidermis. It appears kind of scaly and very rough. Uh, so, all right. So, other environmental factors are sunlight. We actually have this protein P53. It's called a tumor suppression protein. We do have some natural protector cells that will protect us from the ultraviolet radiation from the sun, and one of those is a protein P53. It just protects us from overexposure to the sun, slight overexposure, not laying out for 5 hours every day. Ultraviolet light from sun lamps, tanning beds, will affect our skin tone. X-rays can affect your skin color. Not going into the dentist office and having one X-ray from getting your teeth X-rayed. We're talking like 1,000 X-rays. Physiological factors, oxygenation of the blood. You could appear pink if you have great oxygen. You could appear blue. It's called cyanosis. if you have low oxygen. You could appear gray if you have low blood oxygen levels. Vasodilation, your blood vessels get bigger. Vasoconstriction, your blood vessels tighten up. That would affect your skin color. Accumulation of carotene pigment from diet. So think of like orange fruits and vegetables. I put, all of these down there, or not all of them, but some of them. Your skin can actually turn an orangish tint, and it's usually vitamin A. So carrots and spinach, lettuce, tomatoes, sweet potatoes, broccoli, all this stuff contains vitamin A. So as a side note, we have water-soluble vitamins and fat-soluble vitamins. Water-soluble vitamins, if you take too many water-soluble vitamins, you're just going to use what you can and pee them out. With fat-soluble vitamins, those are vitamins A, D, E, and K. If you take too many fat-soluble vitamins, your body's going to store those. Vitamin A will be stored in your liver. And then if you eat so much vitamin A, I don't want to say overdose, but if you eat carrots every day, like let's say you eat 40 carrots every day, you're going to start to see your skin turn orange because you're eating too much vitamin A, and that vitamin A is getting stored in your liver. And sometimes you'll see this in babies. You think you might be doing the right thing, like, oh, let's give the baby a bunch of fruits and vegetables, and eventually the baby's nose might turn yellow, and it almost has like a jaundiced appearance, but they're not really jaundiced, it's too much vitamin A. All right, so indoor tanning, tanning beds. We do know that, tanning beds cause those melanocytes to synthesize melanin, and that tanning beds make your skin dark. We all know that. But tanning beds use a higher dose of UV radiation than natural sunlight does. And that can, remember we had that P53, or that protein P53, that tumor suppression protein. But in tanning beds, that overwhelms that natural's response to protect the body against UV radiation. So what we see is that UV radiation will increase the risk of developing skin cancer. And what we see is that we'll see some basal cell carcinoma or squamous cell carcinoma in skin. So your skin melanomas arise from the melanocytes that produce melanin. But melanomas are not that common. If you look at all of the skin cancers, only about 4% of skin cancers come from melanomas. However, they cause about 80% of skin cancer deaths. And it's because people just look at it as, oh, it's just a mole. Oh, I don't need to go to a dermatologist. Oh, it'll go away. Oh, it'll whatever. So it goes back, if you see something wrong, go see a dermatologist. You should see a dermatologist, at least once a year, sometimes every 6 months. All right, so the dermis. So we talked about the epidermis. Now we go to the dermis. Remember epidermis, dermis. The dermis is going to be much thicker than the epidermis. This is where we'll see our hair follicles, sweat glands, sebaceous glands, muscles, blood vessels, nerves, stuff like that. And this is actually where your fingerprints are embedded in that dermal layer. In that dermal layer, is going to bind the epidermis to that hypodermis. All right, it says contains these dermal papillae, which are projections of dermal tissue between the epidermal ridges. All right, so what is that? Okay, so let's go all the way back up here. All right, so dermal papillae. See how we have these kind of indents uh, into that epidermis. They don't go into, but it's almost like that egg crate looking thing. Those are dermal papillae. Those little indentations up into kind of pushing or jetting up into that epidermal layer. Those are your dermal papillae. All right. Made up of dense, irregular connective tissue. So remember, we don't see that nice wave-like pattern that we do with dense, regular connective tissue. Has a lot of muscle fibers, nerve cells. We do have that blood supply, those blood vessels that are going to supply the nutrients to the epidermis. We talked about those tactile or Meissner's corpuscles for light touch. But we also have these things called lamellated or Pacinian corpuscles for pressure. So if we go back, all the way up here, we have our tactile Meissner's corpuscles, kind of right there. There's one there. And we also have these things called lamellated or Pacinian corpuscles. So one's for light touch, those tactile. I remember tactile for touch and Pacinian for pressure. So tactile for touch, Pacinian for pressure. All right, so we can, when we look at the, actually, I'm going to move this slide. We'll talk about that. Oh, I actually jumped a slide. Okay, the dermis. The dermis actually consists of two layers. We have a papillary layer and a reticular layer. The papillary layer is less abundant. It's about, I think the textbook says it's about 20% of your dermis, and the reticular layer is about 80%. I think it's much less than that, but no one asked me. But the papillary layer is going to be very superficial, has areolar connective tissue. That's where we're going to find that dermal papillae, and that's where we're going to see our fingerprints. That reticular layer is going to be more abundant. It's very deep. We're going to see that dense irregular connective tissue. It's going to be more thick. Let's see. So if we go back up to this slide, let me just erase everything. All right, so if we just like divide right here. So within our epidermis, everything up here would be the dermal layer, or that papillary layer, and then everything down here would be the reticular layer. So our dermal layer is very thin, our reticular layer is very thick. Dermal or papillary layer, areolar connective tissue, fingerprints, reticular layer, dense irregular connective tissue. All right, so here we just these would be our dermal papillae that kind of bud up into the layer of, or up into the epidermis. So this right here would be the epidermis. So from here to here would be the epidermis. Here to here would be the epidermis. Then we have our papillary layer from about here to here. Remember, areolar connective tissue here, then dense irregular connective tissue down here in our reticular layer. All right, so two thieves steal jewelry and then drop it off as they're escaping. The police recover the jewelry, and officer explains on the evening news that fingerprints were obtained from the back of a watch. The thieves, whose prints are not on file, believe that they can escape prosecution by using acid to remove the epidermis on their finger pads so as not to be a match for their fingerprints on the watch. Why are they wrong? So the two things here are, so they used acid to remove the epidermis. And that's really all we need to know. So they are wrong, but why? The epidermis will rapidly regrow and reform the ridges since they are genetically determined. So they've used acid to remove the epidermis. So our fingerprints are actually in the dermis. So if we use acid to remove the epidermis, we're not removing the dermis, we're just removing the epidermis. So this one's going to be wrong. The epidermis is too thick for the acid to completely remove the ridges. Well, I can tell you, if you dump your hand in a vat of acid, depending on what type of acid, you're going to be able to remove everything down to the bone. So that one's going to be wrong. The prints are due to features of the dermis which are not destroyed. Okay, that sounds like a viable answer. The prints are due to features of the subcutaneous layer which are not destroyed. So no, we know that fingerprints lie in the dermis. All right, so C is going to be our answer. Fingerprints lie in the dermis. So if you remove the epidermis, you did not destroy the dermis. So we're going to go with answer C. All right, some accessory structures. Accessory structures originate from the epidermis. However, they extend into the dermis or the hypodermis. So your hair follicles, nails, sweat glands all originate from the epidermis but extend into the dermis. Let's say you get in a burn or an accident, some of your accessory structures can regenerate depending on if certain areas of those hair follicles or nails can do remain intact, and we'll go over that. So we'll save this statement for hair and nails, and I'll tell you what I'm talking about later on. All right, so for nails, obviously we know what the nails are. We have three parts to the nail. Your nail plate, that's the body of your nail. That's the portion of the nail that you can see. Basically, your nails are just epithelial cells that produce the nail plate, and it's a bunch of keratinized cells. That's why your nail is hard, because there's a bunch of keratin. Your nail bed is underneath the nail itself. So if you kind of rip your fingernail off, you would actually be able to see your nail bed. Um, it's actually the skin. I don't recommend that you rip your nail off, but it's underneath that nail plate. The nail matrix is where your nail grows. So your nail matrix is kind of underneath your finger joint or underneath your finger, kind of underneath your cuticle, back behind your cuticle. You can't see it. Um, all right, we have this thing called a lanula. That's that moon shape on your finger. Oh, I guess I should have advanced your slide. Your lanula. That's that moon shape that's on your finger. That lies over that nail plate. And this is what I was talking about when I was talking about regeneration of the nail. It depends on how involved this area is injured as to whether or not your nail will grow back or how this nail grows back. Or also the nail matrix. Um, the nail matrix down here. Your cuticle, we all know where the cuticle is, right here. Um, It's basically your stratum corneum layer that slightly extends over the nail. Obviously, when you go to the nail salon, it's recommended that you don't cut your cuticles because it's there for a reason, but everyone gets them cut anyway. All right, so hair follicles. We have hair everywhere on our body except for the palms, hands, soles of your feet, your lips, nipples, and some parts of your external reproductive organs. We have these things called hair papilla, and they contain blood vessels to actually nourish the hair. We have um, I'll show you that. There's your hair papilla right there, um, right at the bottom. Your hair color is due, as I mentioned earlier, about the amount of, based on the type and the amount of melanin. I talked about eumelanin for dark hair, pheomelanin for red or blonde hair. We also have muscles that are attached to hair follicles. Those are called erector pili muscles. And those are going to contract in response to cold or fear. That's what gives us goosebumps. So here you can see an erector pili muscle that's attached to the hair follicle. When that muscle contracts, your hair is going to stand up on end and give you goosebumps. All right, hair follicle itself. It's basically a tube-like depression made up of epidermal cells, so basically skin cells. And it says here stem cells come from the hair bulge. So even after a severe burn, you can see new skin grow from the hair follicles. So right here, this hair bulge is right here. So in a burn, if you get burned, if this area survives the burn, then you can possibly see, or you can see, new growth of hair/hair follicles. If that area is injured, then chances of you regrowing hair becomes less and less. All right, 3 parts of the hair follicle: the hair root, hair bulb, and the hair shaft. The hair root, I'll actually start with the hair shaft. The hair shaft is the part of the hair that you can see. It's basically dead skin cells. Remember, it contains keratin. So dead skin cells with keratin. And then I'll go to the hair root, and that's what is kind of underneath your scalp. It's goes from the surface of your skin into the dermis or the hypodermis. And then we have this thing called a hair bulb, and that's the deepest part of the hair root. And that is where those dividing cells of that hair matrix is, so that your hair will grow. So what I'm going to do is hair root, hair bulb, hair shaft. That's what I'm going to do. Kind of put them in order to of what I talk about. So hair shaft, what you can see. Um, then the hair root is underneath your scalp and kind of extends down to about here. And then your hair bulb is going to be down here, and this is where your hair is kind of very much alive and active and grows. All right, hair loss. You actually lose about 20 to 100 hairs a day. Um, and I would bet if you're a female with long hair and you take showers, I would imagine that you lose a lot more hair than that in the shower alone, because I've seen some of the women that our cousin used to live with us, and she had long hair, and I would bet that she loses about 4,000 hairs a day just cleaning up after her. Cleaning her bathroom is just a mess. But anyway, um, so we have the most common type of baldness is called pattern baldness, where you basically lose your hair. It's also called androgenic alopecia. Um, and both males and females can get androgenic alopecia. It's associated with low androgen levels, your sex hormones. For men, it's going to be testosterone, or women, it's going to be estrogen. Um, Obviously, it's going to be more common in men than in women. And it's basically because you have a lack of stem cells being present. So you have these progenitor cells. We talked about those totipotent cells, those um, pluripotent cells. So progenitor cells are lacking in those bald spots. We also have this thing called alopecia areata, and that's an autoimmune disease where your body, you're going to have patchy hair loss. So autoimmune disease basically just means your body is attacking itself. So your body's attacking certain hair follicles, thinking that those hair follicles shouldn't be there, that they are foreign, um, and that causes hair loss. All right, so remember we talked about miracrine, apocrine, and holocrine glands. And, miracrine, apocrine, holocrine. Holocrine was all the way on the right, and it secreted the most gunkiness. The whole cell disintegrated, or most of the cell disintegrated. So it has a lot of um, uh, fat and cellular debris. So this is holocrine glands. We also call these sebaceous glands. They're usually associated with your hair follicles. Like, we don't have those on your palms and soles. They produce this stuff called sebum. So sebaceous gland, SEB, produces sebum, SEB. So fat globules, cellular debris, that's what keeps your hair oily, makes your hair oily. It keeps your hair and skin soft. Remember, fat and oil, they don't mix. So it keeps your hair a little bit waterproof. Now, excess sebum can result in acne. And we'll talk about acne um, right now. So acne, proper name is acne vulgaris. It's a disorder of your sebaceous glands, very common at puberty due to those hormonal changes with your androgens, your estrogen for females and testosterone for males. And those sebaceous glands actually get clogged with that sebum and epithelial cells, which is why you need to keep your face very clean, limited makeup, wash your skin, exfoliate. And when those clogged glands, or when those glands become clogged, great environment for bacteria. Therefore, bacteria, infection, inflammation, acne, acne scars, lots of pustules. But acne affects about 80% of people between 11 and 30 years old. Um, those who are treated with medication, vitamin A derivatives, antibiotics, salicylic acid, which is basically aspirin derivatives, benzoyl peroxide. All right, sweat glands, pseudoiferous glands. I remember this as sweat and um, I say odor, pseudo odor, because sweat can smell, even though sweat really doesn't smell. So very widespread throughout the skin. Um, they're going to originate in the dermis or hypodermis as these kind of ball-shaped coils and going to go up through, or I'm sorry, that's apocrine. Here, merocrine. Merocrine sweat glands. We do have apocrine sweat glands. We'll talk about the difference between the two. Merocrine sweat glands. So they both originate as like these coil balls, and they go up and they release their gunk. So we do have two types of sweat glands. We have eccrine sweat gland or eccrine glands and apocrine glands. And if you remember last chapter, I said that, or maybe it was last chapter, I'm not sure, that eccrine or that merocrine can also be called eccrine glands. Remember that eccrine or that merocrine and eccrine glands release their stuff by exocytosis. They're packaged in vesicles. So they release the least amount of gunkiness. So sweat is basically a bunch of water with some salts, a little bit of waste products respond to elevated temperature. So this is just regular natural sweat. You go for a run, you sweat, you lick your arm, and it kind of tastes like salt and salt water. That's regular sweat, merocrine or eccrine sweat glands. The other type, and that type of sweat really doesn't smell. Apocrine sweat glands. Remember apocrine, merocrine, apocrine, that was the second type of gunkiness where a little bit of the cell pinches off. We find these in axillary, your armpit, and the groin area, down in your pubic region. Those open up into hair follicles. Now, the difference with these, typically apocrine glands, a little bit of their cells kind of pinch off. However, in this case, these apocrine glands, even though they're called apocrine glands, they still secrete their stuff by exocytosis. And these are going to be responding to emotions and pain. And so these are the ones that smell. You smell your armpit, and if you don't use deodorant for, 10 days, you might get a little whiff of something. So these apocrine glands, groin and axillary regions. All right, we also have a third type of sweat gland. We call these modified apocrine sweat glands. Ceruminous glands produce earwax, and mammary glands produce milk. All right, so here's a kind of a critical thinking question. So we know Botox. Um, uh, I think many of you know that, we can use Botox for migraine headaches or, cosmetically to reduce facial wrinkling. But now, also the treatment called Botox works by blocking nerve signals and is typically used to target the muscles of the face to reduce wrinkling. However, some patients with excessive sweating, called hyperhidrosis, have Botox injected into problem areas to reduce the amount of sweating. Why would this work? All right, so nerve signals that stimulate sebaceous glands are blocked. All right, so we're talking about sweating. Sebaceous glands produce sebum, and that's going to be more associated with hair follicles and acne. So we're going to get rid of that answer. Now, if it talked about pseudoiferous glands, then we might have an answer. All right, nerve signals that stimulate apocrine and merocrine glands are blocked. So apocrine and merocrine glands, so those are type of sweat glands. So that might be a viable answer. Nerve signals to the erector pili muscles are blocked, so they aren't stimulated to squeeze sweat from glands. All right, so let's go back to erector pili muscles. They're attached to a hair follicle and they contract in response to cold or fear and they cause goosebumps. Nowhere does it say that erector pili muscles are stimulated to squeeze sweat from glands. So we're going to get rid of that answer. Nerve signals from temperature sensors are blocked, so the sweat glands aren't triggered to secrete when the temperature increases. Okay, so that makes sense. That sounds like a viable answer because as your temperature increases, sweat glands would typically secrete sweat. Now, we have to choose between one of the two. How do we choose? So, some patients with excessive sweating, called hyperhidrosis, these patients are going to sweat. These patients are going to sweat when their body temperature is not only hot, like 98.6 or 99 or 100 degrees, but these patients are going to sweat when they're not hot, 97.6 degrees, 97 degrees. These patients are going to sweat in the air conditioning. These patients sweat in the wintertime. These patients sweat all the time. So I'm more inclined to go with B. Also, if we go back to sweating, we need to account for eccrine and apocrine. Answer B only accounts answer B accounts for both apocrine and eccrine, which is myocrine. Answer D only addresses when the temperature increases. So it only accounts for myocrine or eccrine. So answer B is actually a better answer because it's more encompassing than answer D. All right. Summary slide of what everything does. All right, so as I said before, everything goes back to homeostasis. So what does the skin do? We've talked about some of this before. Protective barrier protects against harmful substances, UV radiation. Remember that we had that protein P53, that tumor suppression protein. Protects against microorganisms from entering the body. Protects against water loss, the epidermis does. Sensation, we have those sensory receptors for touch. Remember those tactile corpuscles, those Pacinian corpuscles. Temperature changes. We have these things called nociceptors that detect pain, thermoreceptors for temperature changes, excretion of some waste. We sweat. Production of vitamin D. Production of vitamin D, it starts in the skin. You go out, about 25% of your vitamin D sunlight needs, or about 25% of your vitamin D needs to come from sunlight. So for those of you who lather up in SPF 4000, you're not doing yourself a favor. You need to get some sort of sunlight every day. So if you live in Miami, and all you need is about 45 seconds to a minute of sunlight exposure to get the amount of vitamin D that you're going to need for the day. If you are outside shoveling snow in Maine and you only have this much of your face exposed, you need about 5 minutes of sunlight per day to get the amount of vitamin D that you're going to need for the day. Now, we know that vitamin D is very beneficial for calcium absorption. Calcium is absorbed through the small intestine. And so if you're, postmenopausal, or if you're hypocalcemic, if you have a low blood calcium, remember calcium is in the bones, osteoporosis. If you take calcium supplements, you're gonna be on vitamin D supplements as well. Regulation of body temperature. We know that sweating helps with regulation of body temperature. You sweat, the wind blows, or you sit in the air-conditioned room. It helps with lowering your body temperature. Adipose tissue. Remember that subcutaneous layer. It conserves body heat. Your adipose tissue conserves body heat. All right. It's obviously very important to regulate your body temperature. Even a slight shift can disrupt your metabolic functions. We talked about the negative feedback loops, and all of your negative feedback loops are monitored by the hypothalamus, which is in your brain. So we want to stay somewhere near 37 degrees centigrade, or 98.6 degrees Fahrenheit. I've said several times that when we do cellular respiration or we break down ATP, we're going to produce heat. If you get a little bit cold, you're gonna shiver. Shivering breaks down ATP. And that heat can get distributed through your body through your cardiovascular system, and then hopefully you warm up a little bit. All right, so we have 4 ways that we lose heat in through our skin: radiation, conduction, convection, and evaporation. Radiation is the primary way that we lose heat. Basically, we're sitting in an environment that is cooler than we are. Right now, I'm sitting in my office. My body temperature is 98.6. My office is 71.8 degrees. The air conditioner is not running. I am losing heat from my body. I'm losing heat by radiation. Conduction. Um, I'll be right back. All right, conduction. I'm holding my Diet Dr. Pepper that I just got out of the fridge. It's cold. Um, the warmth from my hand is getting lost because the can of Diet Dr. Pepper is colder than my hands. So I'm losing heat via conduction into the can of Diet Dr. Pepper. So we'll just set that down, crack it open, have a little drink. All right, convection. Heat loss from the skin into circulating air currents. So I told you that my office was 71.8. If the air conditioner was running, then I would be losing heat because I'm 98.6. Then I would be losing heat through convection. So don't get radiation and convection confused. Radiation is just sitting in a cooler environment. Convection is due to air currents. Evaporation, sweat. Heat loss through sweat as it evaporates. All right, so what happens when our body temperature rises? Remember, these are negative feedback loops. Those thermoreceptors, therm means heat, so we have thermoreceptors on our skin that detect what our body temperature is. And that information is going to get processed in the brain, more specifically the hypothalamus. And what we see is the vasodilation of your dermal blood vessels, those blood vessels in the dermis. And we're not going to go into the difference between, it also says vasoconstriction of your deep blood vessels. We're not going to go in the difference between, your dermal blood vessels, your deep blood vessels, and why those are one vasodilates and one vasoconstricts. We'll talk about that in pathophysiology if you take that course. So anyway, I think we all know when your body temperature rises, you have vasodilation of your dermal blood vessels. Your blood's going to rush to your skin. Your sweat glands are activated. You get flushed. Your skin turns a little bit red, and your sweat glands are activated, and you start sweating. When your body temperature falls a little bit, again, thermoreceptors, hypothalamus, vasoconstriction of your dermal blood vessels. Those are the ones closest to your skin. Your body's trying to conserve heat. Obviously, you don't have any sweat glands that are active. Your body's conserving heat. You start to shiver a little bit. The heat goes through your core. Hopefully, you warm up a little bit. Negative feedback loop. Something's too high, we want to lower it. Something's too low, we want to increase it. Remember that the hypothalamus is the control. Oh, I can't spell. C-O-N, control for the homeostatic mechanisms that maintain body temperature and for all negative feedback loops. All right, so what happens if our body temperature goes way too high or way too low? That's called hyperthermia or hypothermia. Um, Basically, once you get above 104 or below 95 degrees, um, your body's going to start to shut down. You're going to need more medical intervention. Your body can't necessarily correct that. With hypothermia, shivering can only do so much. With both of these, you're going to get weak and dizzy. You might get confused, nauseous, headache. And with both of these, organs are going to shut down. I've seen a temperature of 108 before. They were dead, but that's what the thermometer said. And there are times when we've cooled patients after a heart attack down to 91 degrees. And that was, like I said, after a heart attack to try and preserve brain function. And, they were intubated and we obviously did it on purpose. All right. Elevated body temperature. So with elevated body temperature, I just kind of want to point out just a couple things. Remember that I said as your body temperature rises, those dermal blood vessels are going to vasodilate. And eventually, as your blood vessels vasodilate, your blood pressure starts to drop. And there's a statement down here that says extreme vasodilation can collapse the cardiovascular systems, can be fatal. And that's true. So if your blood vessels vasodilate too much, your heart can't compensate for that extreme vasodilation. And we'll learn next semester about stroke volume and how that relates to blood pressure and the size of your blood vessels. But fever. So when we get a fever, 98.6 is normal. Let's say you have a small infection and your fever goes to 101.5. Now your new normal is going to be 101.5. Your body is trying to fight off an infection, and your body says, hey, 101.5 is normal. I'm not going to try and get you down to 98.6 until we fight off this infection. So that's why it says this set point for the body temperature becomes elevated by the immune system to fight off that infection. And it says phagocytes release these pyrogens in response to the presence of bacteria, viruses, hypothalamus. So the hypothalamus increases that set point and raises your body temperature. Because now we're supposed to be at 101.5. So your body will raise your hypothalamus will raise your body temperature to start fighting off those that infection. And then we have this thing: elevated body temperature helps destroy pathogens. So when the viruses enter your body, viruses need iron in order to replicate. And hemoglobin, that's what carries oxygen and carbon dioxide throughout your body. Hemoglobin contains iron as well. And what we see with with the immune response and with increased temperature, fever, is that your body pulls some of that iron out of the hemoglobin and stores it in your liver. And because of that, the virus has less access to iron, so that viruses have a more difficult time to replicate. So that's one of the good things about having that elevated body temperature. The iron gets pulled to your liver, so the viruses don't have access to that iron, so it will help destroy those pathogens. All right, so I mentioned this inflammation before. You know, it's a natural response to injury, infection, stress. Basically, it's a body's way to restrict the spread of infection. I'm sure we all know this. We'll see, you know, vasodilation of the affected tissue. Whatever is it's gonna swell up. And it's going to allow a lot of stuff, a lot of white blood cells and macrophages and phagocytes to come in. A lot of things are going to come into this damaged tissue. So it's going to become more permeable. And that skin is now going to be reddened, swollen, warm, and possibly a little bit painful to the touch. All right, shallow cuts only affect the epidermis. Remember I said you get a paper cut, you're probably not going to bleed. Deep cut reaches the dermis or subcutaneous layer. You're going to bleed. Remember, blood vessels are in that dermal and hypodermal layer. Releases that and that will form blood clot. So speaking of blood clots, so a blood clot consists of fibrin, blood cells, and platelets. More specifically, white blood cells, some red blood cells, and platelets. And we'll learn about this in one of those chapters next semester. The clotting cascade. Now, that blood clot is eventually going to dry up, and that dry tissue is going to form a scab. So those epithelial cells are going to reproduce to help fill in that wound. And then we have these fibroblasts. Remember, fibroblasts secrete collagen, elastin, and reticular fibers. So these fibroblasts are going to secrete collagen to help bind that wound together. Remember, collagen's very tough, kind of holds things together. Ligaments, tendons are made of collagen. So fibroblasts secrete these collagen fibers to help bind the wound together. And that new blood vessels surrounded by those fibroblasts are going to form this granulation tissue. And then we're going to see these new growth factors stimulate the formation of new tissue. And then we're going to see a bunch of these phagocytes or these macrophages come in and remove the dead cells, that old cellular debris, and eventually that scab is going to slough off. So if we have too much collagen, or too much collagen production during wound healing, we'll see more scar formation. So here's just a picture version of what happened. We cut ourselves with a wound. We'll see some macrophages and some fibroblasts and white blood cells come in. Eventually, we'll see some granulation tissue, regrowth. We'll still see some macrophages and fibroblasts coming in and clean up all of that gunk. The scab forms. We'll see that tissue get regenerated, and eventually that scab is going to fall off. All right, so Jackson has a condition in which his fibroblasts are functional, but very efficient. And they produce collagen at a slow rate. He cut himself on a piece of broken glass. What will his healing process be like? So his fibroblasts are functional, but very inefficient. So they're going to produce collagen, but at a very slow rate. All right, so no blood clot or scab will form. So that's not going to be the right answer. So we have this thing called thrombin, which we'll learn about next semester. It's an enzyme that converts this thing called fibrinogen to fibrin. This basically has nothing to do with collagen. If we go back to here, fibroblasts secrete collagen and bind the wound together. Has nothing to do as to whether or not a scab will form, and has nothing to do with whether or not a clot will form. Clot is epithelial cells to fill in the wound, these growth factors to stimulate new formation. Basically, we're just looking at whether or not his wound will come together. All right. Only the epidermis will heal. The dermis will not heal until he seeks medical intervention. So don't read into this question. This answer is really viable only if there's an underlying clotting issue, which the question doesn't mention. We'll talk about von Willebrand's disease and different types of clotting factor disorders, next semester. So we're going to throw that out. So answer C is going to be our right answer. We still produce collagen, but at a slower rate. So therefore the wound is still going to heal, but it's going to heal slowly. Heavy scar tissue will be produced in and out around the wound. So excessive collagen production will produce heavy scar formation. That's what I told you here. But we're producing collagen at a slow rate. Genetics, severe injuries like deep cuts, burns, lacerations, large surgical incisions, infection, wound tension, and younger age are factors to increase scar tissue formation. So we're going to get rid of D. All right, burns. Burns we can classify as how far deep they go into the different areas of the skin. Superficial or partial thickness burns, we call those first-degree burns. Those only affect the epidermis. So those are going to be like mild sunburns, or if you barely burn yourself on the stove. Those are just going to look like some redness, some heat, inflammation. Those are going to clear up within a matter of a week or so. Not going to see any long-lasting damage, no scars. Deep, partial thickness burns, we call those second-degree burns. Those are going to go into the epidermis and possibly into the dermis. Burns from a hot liquid, for example. You might see some blistering. So like a bad sunburn. Healing is going to vary depending on how severe the burn was and stem cell survival. So, what about that hair bulge, or, what about that lanula or the nail bed matrix? Usually, you're going to recover completely without any scarring. Third-degree burns, we also call them full-thickness burns. they're going to destroy the epidermis, the dermis, associated, the accessory structures. Typically, they go past the hypodermis into the muscle or bone. And that's resulted from repeated or prolonged exposure to heat, flames, hot liquids. You're trapped in a burning house. You can't escape. It's not like oops, I burnt myself and I yanked my hand away. It's I burned myself and the fire is still on there for a prolonged period of time. This is often going to require grafting, skin graft. Um, um, you're going to be you have to cover the injured area with undamaged skin from another area of the body. Now, if you're using your own body, we call that an autograft. So let's say that you get burned on your arm and you take some skin from your butt and put it on your arm. That's an autograft. You also see this in cardiac bypass surgery. Usually they'll take a vein from your leg and make that one of your heart arteries. That's an autograft. If they use someone else's part of your body and put it on yours, that's an allograft. So we'll talk about, there's actually 4 different types of grafts, which we'll talk about later on. But autograft is using your body part or your skin. Allograft, for now, we'll say is using someone else's body part. So we can actually estimate how much of your body is burned using this thing called rule of nines. Your body can be broken up into kind of rule of 9 classifications. Your head is worth 9%. Your arm is worth 9%. Your arm is worth 9%. The front of your body is worth 18%. The back of your body is worth 18, or your back is worth 18%. The front of your leg is 9%. The back of your leg is worth 9%. And then your pubic region would be the 1% to make up 100%. So you will need to know these rules of 9 to estimate the surface area of the burn. So for example, if I told you, or if I asked you, what would the percentage be if the person got burned from basically here on up? So you would do the right arm, which would be 9%. The left arm would be 9%. The front side or the chest would be 18. The back would be 18, and the head would be 9. So 1, 2, 3, 4, 5, 6, 7. 9 times 7 is 63%. Does that make sense? 1, 2, 3, 4, 5, 6, 7. All right. So lifespan changes. As we get older, mitosis slows down. That cell cycle slows down. We're going to see some age spots. Your skin, both your epidermis and your dermis, becomes thinner, which is why older people feel cold. Loss of fat in our subcutaneous layer. Again, older people feel cold. Skin wrinkles a little bit. Our skin becomes drier because our sebaceous glands secrete less oil. Sweat glands decrease. Again, harder to maintain a stable body temperature. Old people get older. Some of us have white hair because our melanin production slows down. Hair thins out a little bit. Might see some balding. Number of hair follicles decrease, might see some balding. Nail growth becomes impaired. Your sensation declines. Your sense receptors decline. So combine that with the increased incidence of diabetes, and people, older people, might have more wounds on their body because they can't tell that they have a sore. So with getting cold more often, you can't regulate your body temperature as effectively. And then decreased ability to produce vitamin D. So you need to be on vitamin D supplements. All right, so that is all I have for this chapter. So I will see you next chapter. If you have any questions, please let me know. Take care.